Similar success rates with frozen oocytes, but increased rate of large for gestational age infants compared to fresh oocytes. Presented by Channing Burks, Reproductive Endocrinology and Infertility Fellow at University Hospitals. I have no financial or commercial relationships to disclose. In 2013, the American Society of Reproductive Medicine stated the following in regard to mature oocyte cryopreservation in a committee opinion. First, that it is no longer considered experimental based on the results of multiple randomized controlled trials. And two, that it is safe and effective in select populations, but that more data is needed before oocyte cryopreservation can be routinely recommended to all women. In recent years, since this committee opinion was published, we have seen a steady increase in the clinical use of frozen oocytes. This is due to a few key reasons. One is the increased societal demand for fertility preservation, which can be performed for both elective and medical indications such as cancer. Secondly, we have seen an increase in oocyte donation and the emergence of donor oocyte banks. And finally, the improvements in cryopreservation techniques, specifically the shift from slow freeze protocols to vitrification, which has resulted in improved oocyte survival post-thaw. To date, there is limited data comparing the clinical outcomes of fresh and frozen oocytes. In a large randomized controlled trial from 2010, which looked at 600 donor oocyte cycles, no difference was noted in ongoing pregnancy rates between the two groups. No difference in live birth rates was observed in a 2013 prospective cohort study of 99 donor oocyte cycles. And a retrospective cohort study from 2014, which analyzed approximately 1,000 children born from frozen oocytes and 1,200 born from fresh, observed no difference in neonatal outcomes, including premature birth, low birth weight, and birth defects. Based on the present literature, there does not seem to be a difference between fresh and frozen donor oocytes. However, to our knowledge, no large-scale studies have analyzed autologous oocytes. Additionally, in contrast to results from studies that have examined fresh and frozen oocytes, epidemiologic studies do suggest that differences exist in neonatal outcomes between fresh and frozen embryos. A systematic review of 2,400 women in a large retrospective cohort study of over 30,000 both found an increased risk for preeclampsia, and multiple retrospective cohort population-based studies have observed an increased rate of large for gestational age infants and macrosomia following frozen embryo transfer. The present literature led myself and my co-authors to ask ourselves some important questions, such as, what impact does oocyte vitrification itself have on pregnancy and neonatal outcomes? And are the effects of vitrification different on the oocyte than they are on the embryo? Our objective was to evaluate pregnancy outcomes of embryos derived from fresh and frozen oocytes in autologous cycles after fresh embryo transfer. This is a retrospective cohort study using the Society for Assisted Reproductive Technology Clinic Outcome Reporting Systems, or SART-CORS, database from both 2014 and 2015. Unlike previous years, 2014 was the first year that SART-CORS counted thawed oocytes as non-research. Therefore, it was the first time that they reported on thawed oocytes and their subsequent linked fresh embryo transfers. The SART-CORS database from 2014 and 2015 were used to identify all fresh and frozen oocyte autologous cycles that resulted in fresh embryo transfer. Generalized linear regression models were used to compare the following pregnancy outcomes: live birth, clinical miscarriage, biochemical pregnancy losses, and birth weight. Models were adjusted for the following factors: maternal age, body mass index, parity, infertility diagnosis, prior in vitro fertilization attempt, or IVF, intracytoplasmic sperm injection, better known as ICSI, assisted hatching, number of embryos transferred, multiple gestation, fetal reduction, and current smoking status. Here's our demographics table. There were almost 140,000 autologous cycles that resulted in fresh embryo transfer between 2014 and 2015 that were analyzed. Even though the majority, over 99%, were fresh, there were approximately 550 frozen oocyte cycles. Mean maternal age in our sample was 35. Mean body mass index was 26. Mean number of embryos transferred was 1.8. Finally, the vast majority of women in this cohort were non-smokers. Our results table focuses on pregnancy outcomes. As you can see here, no difference was observed when fresh and frozen oocytes were compared in regard to biochemical pregnancy losses, 5.8 versus 6.9%, with an adjusted relative risk of 1.3, and a 95% confidence interval that crosses 1. No difference in clinical miscarriages was observed between the two groups, 10.9 versus 11.2 respectively, an adjusted relative risk of 1.04, again with a 95% confidence interval that crosses 1. Finally, when comparing live birth rates between fresh and frozen oocytes, no difference was observed, 25.7 versus 23.9%, adjusted relative risk of 0.94, and a 95% confidence interval that crosses 1. The remainder of our results are listed here in Table 2, which concentrates on the distribution of birth weight. Within this cohort, birth weight was reported for approximately 44,000 fresh and 150 frozen autologous cycles. Although the sample of frozen cycles is much smaller than fresh, the percentage of normal weight infants was the same, 67%. When assessing low birth weight infants, which was defined as less than 2,500 grams, 28% of infants born after the use of fresh oocyte met criteria for low birth weight compared to 20% in the frozen oocyte group. Even though these percentages appear dissimilar, the adjusted relative risk was 0.92 with a 95% confidence interval that crosses 1. Thus, no significant difference was observed. Our final comparison looks at large for gestational age infants at birth, which was defined as greater than 4,000 grams. 4.5% of infants derived from fresh oocytes were born large for gestational age compared to 12.5% of infants derived from frozen oocytes. A significant difference was observed in this group, between these groups, with adjusted relative risk of 2.69 and a 95% confidence interval of 1.66 to 4.33. Before stating our conclusions, I would like to first acknowledge a limitation of our study, which is the small sample size of frozen oocytes that was available via the SART course database to be analyzed. My hope is that with increased use of oocyte preservation, we will have larger sample sizes to analyze in order to better compare fresh and frozen autologous cycles using oocytes in the future. But based on the data that is currently available in our findings, we can reasonably conclude that frozen oocytes have similar live birth rates as fresh oocytes in autologous cycles that result in fresh embryo transfer. Our data does reflect an increased rate of large for gestational age infants after fresh embryo transfer from frozen oocyte. Plausible explanations for this result include that this could be due to vitrification on the oocyte, or alternatively, the difference observed could be due to the difference in uterine environments. As fresh oocytes are fertilized and placed back into a super-ovulated environment, as opposed to frozen oocytes, which post-thaw are fertilized, and their transfer is often timed with a programmed cycle which more closely approximates the natural uterine environment after spontaneous conception. This also could explain why similar results have been seen after frozen embryo transfer in multiple studies, as I stated at the start of my presentation. Our results have not fully illuminated all aspects of this topic, but one thing is clear, that further studies are needed. I would like to thank all my authors. Thank you.